Yeah, good afternoon, everybody. By discussing a patient who presents with a resistant or refractory hypertension, my aim is to convey 5 important messages. Though all of us know a lot about hypertension, but let's journey through this case and get some new information about how do we define resistant or refractory hypertension, how many people have it, whether the problem is serious, what causes it, how to evaluate, and how to treat it. So here goes the case. A gentleman, 70 years, obese, 84 kg, BMI 30, type A personality, hypertension and diabetes for last 6 to 7 years, smoking 5 to 6 cigarettes a day for last 10 years, atenolol 50 milligram per day, hydrochlorothiazide 25 milligram per day, prazopressin XL 5 milligram per day. These are the 3 drugs he has been on. His blood pressure in your chamber is 186 by 104, sitting blood pressure in your office. No major complaints except occasional chest heaviness not related to exertions. He says, sometimes I don't have any specific correlation with anything, and says, my BP is otherwise absolutely normal. I don't have any other problem. So, what will you do? Number one, nothing, as he has white coat hypertension. Anybody agrees to this point? No. So, had it been family physician conference, I believe 50% would have raised their hands. Add medicines as it is refractory hypertension. Anybody agrees to this? Nobody wants to add medicines? All pharma will go to chaos. Take better detailed history. Yes, that is needed because we need to ask about lifestyle. I mean, he has mentioned certain things. We need to ask about certain concomitant medications. We need to get some ideas whether he has secondary hypertension, at least through histories. We should examine him thoroughly. Say maybe sometimes we don't look at the lower limb pulse and patient may have absent pulses. We just define, diagnose, lot of investigations, a bill worth 40,000 rupees and define him as a refractory hypertension, and somebody who's smart will put a hand on dorsalis pedis and says it's coarctation. Investigate for secondary cause. Anybody would like to investigate right now at this stage for secondary cause or would wait for something else? So there are people who would investigate for secondary cause. Change the medicines. That they are not rational, they are not good, let's see. So white coat hypertension is many times a way of escapism and inertia. It's mainly white coat aggravated hypertension rather than white coat hypertension in most of the patients, and that too those who have more than 180 by 100. It's rarely that patient can have 180 by 20, 120 by 80, and now because of your office he goes to 180. So somebody who comes to you with such a severe hypertension on 3 drugs, obesity, diabetes, etc., is not likely to have white coat hypertension, and most of your patients who are with white coat hypertension, many times they are white coat aggravated hypertension. So there are ways to confirm it, and we know that ambulatory blood pressure monitoring is a very important way. It clarifies, say for example, this 38 years old lady, during sleep time BP goes down, during daytime BP is quite normal, so this is normal diurnal pattern, and look at this 80-year lady who has white coat hypertension. The blood pressure at 3 p.m. in the office visit goes up, and then again it's normal. Again next day 3 p.m. when she visits the office, the BP goes up. But it is interesting to understand that white coat hypertension is not entirely benign by itself. The data which have shown and lasted for 10, 12, 15 years have definitely suggested people with white coat hypertension do end up with more stroke as compared to people who are normotensive. So normotensive people who have shoot up of their blood pressure in your office do have bad prognosis as compared to those who remain totally normal. So second point, is it refractory hypertension? Anybody agrees? It's not, then what is it? Let's first define, what is definitions. Uncontrolled hypertension means BP is not at goal irrespective of the reason. If my BP is 160, I am not taking any medicines, I am not following lifestyle, I am uncontrolled BP. Somebody's BP is 160 in spite of 5 medicines, it is uncontrolled. Uncontrolled means you are not at goal, irrespective of anything. Resistant hypertension is hypertension which is there in spite of 3 drugs in optimum dose, preferably 1 is diuretic. So this patient is already on 3 drugs, almost optimum dose, and 1 was diuretic. Controlled but resistant hypertension. When BP is controlled by more than 3 drugs, it is called controlled but resistant, while refractory means truly uncontrolled blood pressure. There is a huge prevalence of uncontrolled blood pressure even in the best countries and societies of the world, and even if people are taking medicines, there is a huge prevalence of uncontrolled blood pressure. As the age increases, the chance of having uncontrolled BP goes high. So what is the rationale behind discussing a case of uncontrolled hypertension? Very simple. Identify people who are at higher than usual risk, number one, and identify people where by investigations you can find out some cause, and if you remove the cause, you can cure or help the patients. Now, if a patient has got refractory hypertension, his chance of having variety of end organ damage is very high. LVH, carotid intima media thickness, carotid plaques, and retinopathy, everything goes high. There are so many causes, but just to define under few headings, improper BP measurement can lead to what is called as persistent or resistant blood pressure, failure to adhere to a regime. There are certain substances like sodium excess, alcohol excess. There are certain medicines like steroids, and very important, NSAIDs, they all lead to either increase in blood pressure or deterioration of control of BP, or they increase the demand of medicines. So NSAIDs are notorious drugs. There can be fault with the medicines which we have prescribed may not be in adequate dose, may not be in proper judicious combinations. There can be certain complicating biological factors like obesity, metabolic syndrome, and a very important point, obstructive sleep apnea, or patient can have secondary causes. So these are the agents, as I told, which may impair the blood pressure control: steroids, NSAIDs, amphetamines, sex hormones, immunosuppressive agents, erythropoietins, certain dietary supplements, etc. And there are certain patient characteristics which suggest the chances of resistant hypertension. They are elderlies, obese people, people with high salt ingestion, people with chronic kidney disease, people with diabetes, etc. So your patient, you remember your patient, 70 years, obese gentleman, diabetes, smoking, blood pressure, 3 drugs, BP is high. So on detailed history, what you obtain is he has uncontrolled blood pressure, almost resistant because he is on 3 drugs. He has multiple risk factors which is causing resistant blood pressure like obesity, age, diabetes, and he is a food lover. He smokes more than 10 cigarettes on detailed history as he has a habit of snoring. That is what he says his wife used to complain, and he sleeps easily during the daytime. Occasionally he drops his medicine. Someday he says it's fine, I don't take, and takes when required painkillers for joint pain. So these are very important points on detailed history. Ask every elderly who comes to your office with blood pressure whether he takes painkiller or not. Maybe to your surprise, more than 25% people do take it. And he gave a history that he needed one short episode of hospitalization for winter bronchitis, what was told to him. That was for 1.5 days, and he had some breathlessness, and ECG was normal. He was not detailed investigated. So in your patient, you have suggested lifestyle modification, weight loss, diet plan, salt intake, physical activity, alcohol stopping, etc., etc. And certain diagnosis you should be doing, at least basic investigative tests. And these are must in every patient who comes to you on the first visit for hypertension, because of a lot of importance attached to all these tests. Other more extensive and costly tests to identify secondary causes is not required in majority of the patient at first visit. And in your patient, these are the values. ECG has LVH, sugar is 176, hemoglobin is okay, potassium is borderline low, creatinine is borderline high, calcium is normal, lipid profile is abnormal, urine analysis there is microproteinuria. His echo also shows LVH, mild MR, 50% ejection fraction with mild apical hypokinesia, and glycosylated hemoglobin is 8. So these are the investigations you got for him. Why do we investigate a patient with high blood pressure? There are 3 issues. Number one, you want to identify the target organ damage. If a patient has got target organ damage, his risk of death or cardiovascular event is higher. So that is very important point. Second, you want to assess the secondary cause, and that's why you investigate. There is now plenty of data that a patient with microproteinuria at any given level of blood pressure has a higher chance of cardiovascular event as compared to patient without microproteinuria. So that's a very important test. A person with LVH has a much higher risk as compared to a person without LVH. And we all know that diabetes leads to increased mortality and complications at any given level of blood pressure. So it's important to find them out. So in this patient, your decision so far, if anybody disagrees heavily, tell me. It's hypertension, maybe essential, maybe something else, but it is resistant to treatment. You have strongly recommended therapeutic lifestyle changes to him. You have changed medications for high blood pressure, and you know that goal is 130 by 85. Tell me certain 80 milligram hydrochlorothiazide, 12.5 milligram amlodipine, 10 milligram at this stage. Better control of diabetes you advocated, you ask him to come after 1.5 months, and you know that he is surely a high risk patient. So this is what you can do on the first visit, some investigations, and you have changed the treatment. You know this. There are guidelines that yes, a person with diabetes needs certain specific medicines, and that's why you prescribe ARB, small dose of diuretic, and amlodipine in a good dose. After 40 days, he comes back to you. He feels okay, takes regular medicines now, more than 50% adherence to lifestyle. He has stopped smoking. He has lost 3 kg of weight. His BP records, which he has measured at with GP, says systolic is around 160, diastolic around 90-95. So he has better control, not control, but better. What will you do now? Add medicines, beta blockers. It is the 4th step, and you have already 3 drugs. So anybody agrees to add beta blocker to cut down sympathetic activity? His pulse is 84 at your clinic. Beta blocker addition, few people say yes. Who wants to add centrally acting drugs? Powerful drug, you need powerful drugs. Arcamin like drugs, anybody? No? Why? Workup for secondary cause, detailed workup? No? And anybody wants him to get admitted for intravenous nitroglycerin, nitroprusside, etc.? No, so that's very important, yes. Now say, there are certain features called as features suggestive of inappropriate hypertension. If they are present, you need to investigate a patient for secondary cause. What are they? If BP onset is before 20 years or after 60 years of life, if there is resistant severe high blood pressure, if there are features suggestive of organ damage like retinopathy grade 2, creatinine 1.5 or more, LVH on ECG, these people must be investigated for secondary cause, because there are higher chances that you may find some secondary cause. People with unprovoked hypokalemia, abdominal bruit, poor response to treatment, etc. So these are the important secondary cause, though there is a huge list, but for your practical purpose you must remember these 5, 7, 8 conditions. Common are obstructive sleep apnea, which this patient does have to some extent, which responds to weight loss initially. Renal parenchymal disease, primarily aldosteronism, renal artery stenosis, pheochromocytoma, Cushing's, parathyroid, coarctation, and intracranial tumor. So these are important points, and out of this all, we know that this patient has got creatinine 1.5, resistant hypertension, potassium 3.1, and you may feel that you need to investigate him for maybe kidney purpose, etc. But before that, let's have a look. How many percentage of people do have secondary hypertension? Overall, 5 to 7% people, depending upon the series studied, have secondary cause of hypertension. The common is occipit and steroid-induced and renovascular. But if you take a cohort of resistant hypertension, maybe 20 to 30% people do have secondary cause. So once you have stamped a BP to be resistant, it's a very high chance that this patient will have secondary hypertension, and you need to investigate thoroughly. So depending upon our analysis so far, this patient must be thought for kidney purpose for the first, and then since he had low potassium, we should keep in mind about primarily aldosteronism. So yes, you got certain tests done, ultrasound and Doppler. Right kidney is 9.6, cortex is 9, maintain CMD. Left kidney is 10.5, cortex is 9, maintain CMD. So do you appreciate any difference here? No? Severely stenotic flow pattern at origin of right renal artery, more than 75% narrowing. So that does suggest he has renal artery stenosis, with the same kidney having little less size as compared to the opposite kidney. His creatinine has gone up. Maybe perhaps we started telmisartan, and that must have resulted. If he has beta, potassium is normal, rest of the things fine. So obviously once patient has Doppler study suggestive of renal artery stenosis, we should subject a patient for renal angiogram. And when this patient was subjected for renal angiogram, he was found to have critical narrowing at the ostium of right renal artery. So, I mean, there is no scope to discuss the justification of renal artery stenosis stenting, but this patient did need it because of poor control of blood pressure. And then he was stented, a stent 7 by 12 millimeter was implanted at the ostium. There was brisk flow and urine output was there. Patient did show signs of improvement, and by next 24 hours, 48 hours, he started having good blood pressure. He is still on the same medicines. His creatinine after 2 days was 1.4, and there was no episode of flash edema. So people who have resistant hypertension do need investigations and correction of them. There are certain newer things on the horizon, endothelin antagonist, but so far poor outcomes. Vaccination for blood pressure, maybe someday it may be a truth. Long-acting IV or IM preparations which can be given and can have effects for weeks or months. Gene manipulation has a promising future, and renal sympathetic denervation, which I'll discuss for a few seconds. There was this study published in the Lancet, catheter-based renal sympathetic denervation for resistant hypertension. So these were the patients, and we know that the afferent and efferent flow to the nervous flow to the kidney the nerves runs in the adventitia of the renal arteries. So like what Dr. Ajay Naik does for SVTs and variety of other arrhythmias, you take your ablation catheter to this part of renal artery and ablate at certain areas, so that will cut off certain nervous supply to the kidney. And primary data has suggested that once you do it, there is significantly higher chance that you have a good control of blood pressure. So this is something on horizon. So take home message, my dear friends, we can improve the outcome of people with a serious hypertension. Number one, do not be satisfied when patient is not at goal. This is the single most important point I would like to mention. Most of the times patient wants a positive answer that yes, your BP is otherwise controlled, in only my chamber your BP is up, so don't worry. Please avoid this answer. This is the most notorious answer we can give to most of the patients. Ensure that BP is measured properly. Always consider non-adherence. People do not take adequate medicines at proper time. So always think on these aspects. Ask leading questions about concomitant medicines. Ask them, do you take any painkiller any day, any time? And they will say yes. Nobody lives a good lifestyle. So explain them good lifestyle. But before that, we need to live a good lifestyle. Actively reject that secondary cause is present and evaluate guided by clinical clues. Always believe in a patient with resistant hypertension that there is a secondary cause and I want to get it at any how. Rationalize therapy and don't hesitate to use multiple drugs. Thank you very much for your kind attention.